Good afternoon. My name is Georandy Bernard, a third year doctor of pharmacy candidate from Miami, Florida. And for my journal club, I decided to do a journal by the name of Intensive Blood Glucose Control and Vascular Outcomes in Patients with Type 2 Diabetes. I found this journal entry in the New England Journal of Medicine from the year 2008. The authors include A. Patel, S. McMahon, J. Chalmers, B. Neal, and L. Billett. We see that this particular trial was funded by the National Health and Medical Research Council of America. Now, for a little bit of background information, we can see that the prevalence of diabetes is increasing worldwide, and most people with diabetes will actually die or be disabled due to consequences of micro or macrovascular complications. And prospective studies have shown continuous associations of increased blood glucose and glycated hemoglobin levels with the risk of major vascular events. Um, a modified release controlled evaluation trial was designed to assess the effects on major vascular outcomes of lowering the glycated hemoglobin value to a target of 6.5% or less in the section of patients with type 2 diabetes. The objective of this clinical trial was to lower the average glycated hemoglobin value to 6.5% in patients type 2 diabetes, as stated before, and also to reduce the incidence of combined primary outcomes of major macrovascular or microvascular events. The trial design was prospective, it was multi-centered, and it was a randomized trial. It was held in many different locations: Asia, Europe, Australia, and mostly North America. It was approved by the Study Center's Ethics Committee, so each location, Asia, Europe, Australia, and North America, each had their own study center, and so it was up to the ethics committee to get this study approved, as well to get signed consent from those participating in the trials. The inclusion criteria included patients diagnosed with type 2 diabetes by the age of 30. You have to be 55 years of age by the time of the study, and you have to have history of macrovascular diseases or at least one other risk factor for vascular disease. The exclusion criteria included anybody who had contradiction to any long-term insulin therapy at the time of the study entry. The subjects were patients who were 55 years of age who were diagnosed with diabetes, type 2 diabetes by the age of 30. With the primary endpoint, we see that there were composite of macrovascular events and a composite of microvascular events, and they were both considered both jointly and separately. The pre-specified secondary outcomes were death from any cause, such as cardiovascular causes, cerebral vascular events, heart failure, peripheral vascular events, any other cardiovascular events, new or worsening neuropathy, any retinopathy, or any hospitalization for the past 24 hours due to severe hypoglycemia. Follow-up for the two different groups. The intensive group patients were seen the second week after they had been randomized and given the different medications, and then again at months 1, 2, 3, 4, and 6, and then every 3 months thereafter. And patients who were receiving the standard control therapy were seen at months 3, 4, and 6 after they were randomized into the study, and then every 6 months after. The study lasted for 5 years, and it had a population of 11,140 randomized patients or participants. 86.5% of those who were a part of the original 12,877 who were potential eligible participants. The arms of this experiment or this clinical trial, patients who were randomly assigned to undergo intensive glucose control were given gliclazide, 30 to 120 milligrams daily, and they were required to discontinue any other sulfonylurea use. Patients in the standard group control who were using gliclazide already, when they entered the study, they were told to substitute that drug with another sulfonylurea. Now, this trial was originally designed to have a statistical power of 90% to detect a relative risk reduction of 60% or more. when comparing the intensive control with the standard control. For each of the primary outcomes, we used the two-tailed test with an alpha level of 5%, and we saw that all the p-values were two-sided, and they had a p-value of less than 0.05, so they were considered to indicate statistical significance. Now, when it came to our results, first with baseline characteristics, the average baseline hemoglobin was 7.5%, and the mean fasting blood glucose was 8.5 millimoles per liter. And so at baseline, we found that 91% of the patients were receiving oral hypoglycemic agents. With the primary endpoint, a total of 2,125 participants had major micro or microvascular events. So that was about 18% in the intensive group and 20% in the standard control group. In the intensive group, there was a significant reduction in the incidence of major microvascular events, but not in the incidence of major microvascular events. The secondary endpoints, there were a total of 1,031 participants who passed away. About 9% was in the intensive control group, and close to 10% was in the standard control group. The intensive control group was associated with a significant reduction in renal events as well, and that would include new or worsening nephropathy. A side effect that was seen from both groups was severe hypoglycemia, but it did occur more frequently in the intensive control group than in the standard control group. In the intensive control group, there are about 150 patients who had at least one severe hypoglycemic episode, as compared to 81 patients in the standard control group. In conclusion, from the author, we see that an intensive glucose control study involving glycoside and other drugs as required lowered the average glycated hemoglobin value to 6.5% in a broad range of patients with type 2 diabetes, and reduced the incidence of the combined primary outcome of major microvascular events and macrovascular events. The main contributor to the 10% relative reduction in the primary outcome found with intensive control as compared to with standard control was 21% relative reduction in the risk of new or worsening nephropathy. There was no evidence of a reduction in macrovascular events. Intensive glucose control was associated with an increased risk of severe hypoglycemia and an increased risk of hospitalization as compared with standard control. There was no evidence that the effects of the intensive glucose control were dependent on the baseline glycated hemoglobin or blood glucose levels, age, sex, or presence or absence of history of any vascular disease. A couple strengths that this clinical trial had, that it was multi-centered, and it had a large sample size that was distributed among the different countries, and it had a long duration. It lasted for 5 years, so that gives us a significant amount of time to see what type of results come from this clinical trial. A weakness that I found was that the funders of the study were actually people who manufactured the medications, the glycoside, and also any sulfonylurea such as glyburide. There was the funders of those, the manufacturers of those medications were the funders of this clinical trial. So I see that now might have put a little bit of bias. So that would probably be the biggest weakness to this trial.